Hello and welcome to the topic Psychiatric Emergencies in the module Psychiatry. By the end of this session, you should be able to define psychiatric emergencies, identify types of psychiatric emergencies, and explain the approach in psychiatric emergencies. Let's get started. Psychiatric emergencies are conditions requiring psychiatric interventions which may include attempted suicide, substance abuse, depression, psychosis, violence, or other rapid changes in behavior. Care for patients in situations involving emergency psychiatry is complex. Let's take a look at the types of emergencies. So you may encounter various situations which warrant emergency psychiatric consults. Let's learn the common ones which we usually encounter in practice. Firstly, suicide attempts and suicidal thoughts. So as of the year 2000, the World Health Organization has estimated 1 million suicides in the world each year. There are countless more suicide attempts. Psychiatric emergency service settings exist to treat the mental health issues associated with an increased risk of completed suicide or suicide attempts. And among other psychiatric emergencies, one needs to be familiar and well-versed with include violent behavior, psychosis, substance dependence, abuse and intoxication, hazardous drug reactions, personality disorders that can lead to serious problems, disaster, and not forgetting abuse. Aggression can be the result of both internal and external factors that create a measurable activation in the autonomic nervous system. This activation can become evident through symptoms such as the clenching of fist or jaw, pacing, slamming doors, hitting the palms of one's hands with fist, or being easily startled. It is estimated that almost 20% of visits to psychiatric emergency service settings are homicidal in origin, and about an additional 5% involve both suicide and homicide. Violence is also associated with many conditions such as acute intoxication, acute psychosis, paranoid personality disorder, antisocial personality disorder, narcissistic personality disorder, and borderline personality disorder. Additional risk factors have also been identified which may lead to violent behavior. Such risk factors may include prior arrests, presence of hallucinations, delusions, or other neurological impairment. Now let's take a look at psychosis. So patients with psychotic symptoms are common in psychiatric emergency service settings. The determination of source of the psychosis can be difficult. Sometimes patients brought into the setting in a psychotic state have been disconnected from their previous treatment plan. An individual could also be suffering from an acute onset of psychosis. Such conditions can be prepared for diagnosis by obtaining a medical or psychopathological history of a patient, performing a mental status examination, conducting psychological testing, and by obtaining neuroimages. Acute psychosis is classified as a medical emergency requiring immediate and complete attention. The lack of identification and treatment can result in suicide, homicide, or other violence. How about substance dependence, abuse, and intoxication? These acute symptoms may resolve after a period of observation or limited psychopharmacological treatment. However, the underlying issues such as substance dependence or abuse is difficult to treat in the emergency department as it is a long-term condition. So both acute alcohol intoxication as well as other forms of substance abuse can require psychiatric interventions. Alcohol in excess intake can cause impaired concentration, verbal and motor performance, insight, judgment, and short-term memory loss, which could result in behavioral change causing injury or death. Episodes of this impairment usually consist of confusion, disorientation, delusions, and visual hallucinations, increased aggressiveness, rage, agitation, and violence. Chronic alcoholics may also suffer from alcoholic hallucinosis, wherein the cessation of prolonged drinking may trigger auditory hallucinations. Antipsychotics are often used to treat these symptoms. The next emergency would be hazardous drug reactions and interactions. Overdoses, drug interactions, and dangerous reactions from psychiatric medications, especially antipsychotics, are considered psychiatric emergencies as well. Neuroleptic malignant syndrome is a potentially lethal complication of first or second generation antipsychotics. If untreated, neuroleptic malignant syndrome can result in fever, muscle rigidity, confusion, unstable vital signs, or even death. Serotonin syndrome can result when selective serotonin reuptake inhibitors of monoamine oxidase inhibitors mix with buspirone. Severe symptoms of serotonin syndrome include hyperthermia, delirium, and tachycardia that may lead to shock. Now let's take a look at personality disorders. So disorders manifesting dysfunction in areas related to cognition, affectivity, interpersonal functioning, and impulse control can be considered personality disorders. Patients suffering from a personality disorder will usually not complain about symptoms resulting from their disorder. And patients suffering from an emergency phase of a personality disorder may showcase combative or suspicious behavior, suffer from brief psychotic episodes, or could be delusional as well. Natural disasters and man-made hazards can cause severe psychological stress in victims surrounding the event. Emergency management often includes psychiatric emergency services designed to help victims cope with the situation. The impact of disasters can cause people to feel shocked, overwhelmed, immobilized, panic-stricken, or confused. Hours, days, months, and even years after a disaster, individuals can experience tormenting memories, vivid nightmares, develop apathy, withdrawal, memory lapses, fatigue, loss of appetite, insomnia, depression, irritability, panic attacks, or even dysphoria. Unless a condition is threatening the life of the patient or others around the patient, other medical and basic survival considerations are managed first. Next, let's take a look at abuse. Incidents of physical abuse, sexual abuse, or rape can result in dangerous outcomes to the victim of the criminal act. Victims may suffer from extreme anxiety, fear, helplessness, confusion, eating or sleeping disorders, hostility, guilt, and shame. Managing the response usually encompasses coordinating psychological, medical, and legal considerations. Let's now look at the approach to psychiatric emergencies in a whole. As you approach the patient, begin with triaging. This includes understanding the patient and the severity of the condition. This follows with understanding the surrounding of the patient and others around. Next is gauging the safety of the involved parties. Usually a code grey is activated should there be any forms of physical assault or aggressive person within the hospital vicinity, and code green is activated for suicide attempts identified. Otherwise, if the situation is still under control, the psychiatry team will receive the referrals either from the periphery wards or from the emergency room. Following triage, if there are minor or major symptoms, assessment ensures and dispositional options are thought of. This is then followed by a treatment planning. If there are life-threatening symptoms, crisis stabilization is warranted, followed by treatment planning. Let's now look at the various methods of treatment of psychiatric emergencies, beginning with medications. So a common route of administration is oral administration. However, if this method is to work, the drug must be able to get to the stomach and stay there. In cases of vomiting and nausea, this method of administration is not an option. Suppositories can in some situations be administered instead. Medications can also be administered through intramuscular injections or through intravenous injections. As for psychotherapy, these are other treatment methods that may be used in psychiatric emergency service settings. Brief psychotherapy can be used to treat acute conditions or immediate problems as long as the patient understands his or her issues are psychological. Electroconvulsive therapy or ECT is a controversial form of treatment which cannot be involuntarily applied in psychiatric emergency service settings. Instances wherein a patient is depressed to such a severe degree that the patient cannot be stopped from hurting himself or herself, or when a patient refuses to swallow, eat, or drink medication, electroconvulsive therapy could be suggested as a therapeutic alternative. While preliminary research suggests that electroconvulsive therapy may be an effective treatment for depression, it usually requires a course of 6 to 12 sessions of convulsions lasting at least 20 seconds for those antidepressants effects to occur. Now, to recap, psychiatric emergencies are psychiatry and its related conditions which warrants immediate attention by psychiatrists. Examples of these conditions are suicide attempts and suicidal thoughts, violent behavior, psychosis, substance dependence abuse and intoxication, hazardous drug reactions and interactions, personality disorders, disasters, and abuse. Approach to psychiatric emergencies begin with triaging a patient, and once life-threatening circumstances have been excluded, a thorough assessment can be done to determine the therapy required. On the other hand, should there be a life-threatening situation, crisis stabilization is required first. Now we have come to the end of this topic. Thank you for your time.